The ASPEN study is a phase 3 study comparing Ibrutinib versus Zanubrutinib in patients with Waldenström's Macroglobulinemia. And this is really quite exciting because it is really the first published study, or first finished study, comparing head-to-head two different BTK inhibitors, the first generation BTK Ibrutinib and the second generation Zanubrutinib in any disease. So just to recap, Ibrutinib is a very effective drug in patients with Waldenström's Macroglobulinemia. However, there are a few drawbacks to Ibrutinib, namely its side effects being bleeding, atrial fibrillation, and other things such as diarrhea, edema, muscle spasms, and so forth. And a lot of these side effects were thought to be potentially due to off-target inhibition of other enzymes. So Zanubrutinib has advantages over Ibrutinib in two ways. So firstly, it is more targeted, so potentially can have less side effects. And secondly, the drug levels are very high and it penetrates into deep tissue sites very well. So potentially it could be even more effective than Ibrutinib. And indeed, from the long-term follow-up of the phase 1 study of Zanubrutinib, which included patients with Waldenström's, and that study is also reported at this same ASCO meeting, we saw that there is quite a high VGPR rate, a very good partial remission rate, which means a 90% reduction in the IgM level for Zanubrutinib, substantially higher than that expected of Ibrutinib. So ASPEN is designed as a head-to-head study. Patients who have got an MYD88 mutation and Waldenström's are randomized 1-to-1 to receive either Ibrutinib at the standard dose of 420 milligrams daily or Zanubrutinib at 160 milligrams BRD. In total, 201 patients were enrolled, and at the time of this study follow-up, we're reporting a median follow-up of 19.4 months. And what we saw was that at this point in time, the primary endpoint, which is the very good partial remission rate as assessed by the Independent Response Adjudication Committee, or the IRC, was in fact not statistically different between Ibrutinib and Zanubrutinib. So this rate is 19.2% for Ibrutinib and 28.4% for Zanubrutinib, and the p-value for this difference is 0.092. So this is so the primary endpoint of the study was not met. However, if you look at the investigator-assessed response, especially when we look at the investigator-assessed response of an additional 5 months of follow-up in January of this year, we now have a significant p-value in favor of Zanubrutinib because the VGPR rate with further follow-up has now matured to 30.4% compared to 18.2% for Ibrutinib, for p-value difference of 0.03. But so there is a suggestion that perhaps that the primary endpoint was underpowered, as read by the IRC, and with more prolonged follow-up and more patients heading into VGPR, there does appear to be a superior outcome for Zanubrutinib. But really the biggest advantage is intolerability. And true to the Zanubrutinib being more targeted than Ibrutinib, we saw much better tolerability for Zanubrutinib, with a reduction in the number of fatal adverse events, the number of adverse events that led to either dose reduction or dose hold or treatment discontinuation. And when one examines the adverse events one by one, Zanubrutinib was associated with a reduced number of patients with diarrhea, contusion, muscle spasm, peripheral edema, hypertension, atrial fibrillation, and pneumonia. And really, the only disadvantage of Zanubrutinib was an increased rate of neutropenia, which importantly did not translate to any difference in infection rates, which were identical between the two arms. Now, I just want to drill down on the atrial fibrillation rates, because this is really, I think, very important, because atrial fibrillation is a real problem for patients on BTK therapy, and especially in my experience in patients with Waldenström's, because I suspect that many Waldenström's patients in fact have underlying amyloid cardiomyopathy and don't know about it. So the atrial fibrillation rate at the latest follow-up of Zanubrutinib versus Ibrutinib was in fact very high at 18.4% in the Ibrutinib arm and only 3% in the Zanubrutinib arm. So it's a 6-fold difference in atrial fibrillation rate. In addition, the rate of hypertension is much lower with Zanubrutinib compared with Ibrutinib. So in conclusion, this is the first head-to-head study of Zanubrutinib versus Ibrutinib in any disease, the first head-to-head study of two BTK inhibitors in any disease. And although the study missed its primary endpoint, there are lots of secondary indicators to suggest that Zanubrutinib is a more effective drug. But what is not in doubt is the fact that Zanubrutinib is in fact much better tolerated with a far lower risk of important adverse events, including cardiotoxicity.